There we go. All right, we're going to get started with the Kahoot. 1 second. Please get logged in. Get started, guys. This is the Kahoot over chapter 11. To review that. All right, question 1. What is decontamination? All right, decontamination is referring to the mechanical removal of microbes, typically referring to inanimate surfaces, but it's a term that can be applied to animate surfaces as well, as it turns out. But remember, removal of all microbes would be sterile after that. So that's the term for that one. And removing microbes from a living surface is asepsis or antisepsis. Antisepsis. So we've got our next question. What is asepsis? Sepsis or antisepsis, right? This is removal of those microbes from animate surfaces like living skin. All right, our next question. What does it mean the method is microbicidal? The correct answer for this one is it kills microbes. So microbicidal, cidal is always referring to killing and not just inhibiting. And we are affecting microbes, generally speaking, not just bacteria. All right, next question, number 4. Which one sterilizes? All right, so it's incineration and dry oven for this one, so they both could be correct. Boiling and freezing do not sterilize. Remember, boiling just decontaminates or disinfects is a better word for that one. Boiling will disinfect. Incineration and dry oven, if used appropriately, can sterilize.
Honestly, the way I remember that is the way you were talking about it. Boiling water does not.
I can't say it enough. I can't say it enough. So if you guys take anything out of that, at least hopefully you've learned that. All right, which one of the following sterilizes yet again? Hopefully I updated this one. All right, so pasteurization is the only one on here that can't sterilize. So pasteurization, we're removing most of the pathogens, but we're not removing all of the microbes. If you use autoclaves correctly and ionizing radiation correctly and UV radiation correctly, they can sterilize. Now, UV radiation is only going to sterilize surfaces. It can't penetrate, whereas the ionizing radiation can penetrate through things and sterilize throughout the entire object. So there's some limitations with UV radiation, but UV radiation can sterilize surfaces. It's not typically used for that, but it could. All right, true or false? There are no liquid cleaners that can achieve sterilization. Right, so this one is false. Most of us got this one. So when we think about the halogens, several of the halogens can sterilize if used appropriately. Even hydrogen peroxide can sterilize at high enough concentrations, not over the counter concentrations, but again, 35% or higher. And then our glutaraldehyde and formaldehyde can also sterilize. But again, we have to be using them at the right concentration for the right amount of times and everything like that. So isopropyl alcohol is preferred over ethyl alcohol for asepsis, antisepsis. It's true or false? Talking about the effectiveness of the disinfection, the antisepsis of it, the effectiveness of it. All right, so this is true. Isopropyl alcohol works better and it's cheaper. Ethyl alcohol doesn't work as good, but remember, ethyl alcohol won't break down your skin barrier as quickly. So we actually see even this is ethyl alcohol, but the reason that they have it is it won't break down your skin barrier as much. So you keep using isopropyl, you're going to dry out your skin and then have cracks in the skin and then be more susceptible. But as far as the effectiveness of the actual chemical goes, isopropyl alcohol is actually more effective, but it'll dry out your skin over time if you use too much of it. All right, all those alcohol prep pads that we use, those are isopropyl. So which of the following is not a halogen? All right, so a lot of us got this one. This is ethylene oxide. That was our gas that we can use as a chemiclave, remember a chemical to treat everything in the room. But bleach, fluoride, and iodine, those are all like fluorine, bromine, chlorine, and iodine are all our actual halogens. That's the second row over from the right on our periodic table of elements. And so those are all going to fall into that halogen category. And if used in the right concentrations for the right amount of times, can potentially sterilize. All right, question 9. From these choices, which are the most difficult pathogens to eliminate completely? All right, so this is going to be endospores by far. typically our viruses are enveloped viruses.
It's wrong.
Oh, I clicked the wrong thing. But yeah, endospores, you guys got it right. I just have to update the quiz. You guys got it right. So I just checked the wrong box, but it's endospores by far. With this one, typically the enveloped viruses, the ones that have a membrane, are actually the most sensitive to our methods of sterilization and disinfection. Then it's the ones without the envelopes. Then we get into the bacteria, and then it just depends on the bacteria. A lot of times the gram-positive cells are more hardy than the gram-negatives, but it just kind of depends. There's some overlap there. Endospores are by far the hardiest of all of the cells. But then there's something that we never mentioned in our talk last time, which is prions. You guys remember prions and what they are? Misfolded proteins, right? Those are actually harder to get rid of than endospores. So endospores we can sterilize. Endospores we can sterilize at 121 degrees Celsius, 15 psi with steam in the autoclave. But if you want to get rid of prions, you're going to have to crank it up to 135 degrees Celsius. And you're going to have to use things like sodium hydroxide to chemically break down the proteins. In fact, it's so hard to get rid of the prions that we have to have special procedures in place at hospitals if we think there is a prion involved. So if you had a patient with dementia who you didn't see any reason for them to have dementia and you wanted to test for a prion disease, you're going to have to call up to the lab and tell them you've got a potential prion coming up, because they're going to have to prepare for special sanitization processes in order to get rid of the potential prions that could be contacting their equipment and countertops and things like that, because those things are nearly impossible to eliminate completely. Even regular incineration doesn't get rid of prions. Cooking meat doesn't get rid of prions. So that should put that in perspective. But when we talk about prions and how they're 100% fatal and how, you get contaminated with it and 30 years later, you'll have these symptoms and there's no treatment for them and everything like that. But they're incredibly rare also. We just don't see them a lot. At least we think that anyways. So as far as what we can tell from what we know about them. So prions are actually worse than endospores, just FYI. But for our basic knowledge, endospores should be the king. So we got that one right. Don't hold it against yourselves. So how do surfactants work? I'll have to update that one. That was chapter 11. Y'all know my online class had to do that by last week and nobody emailed me about that question being wrong. That tells you how much they pay attention to what they're doing. All righty. So surfactants, how do they work? Surfactants are going to disrupt cell membranes by mimicking those phospholipids, right? They have a charged head and a nonpolar hydrophobic tail, and they're going to mimic the phospholipids themselves, disrupt the cell membrane by doing that. All right, here's our podium. I have a different question on that one.
Maybe it's not their fault.
Right. We'll just say that. Okay. All right, good job. So we're going to move on to our lecture for today, which is chapter 12. You guys are going to have to give me a little bit of a break. I threw out my back on Thursday, like really bad. Like I couldn't even get out of bed on Monday. And you guys got my message about how I had a flat tire? Yeah. Right. So I ran over something over by the Impact Center. If you know where that is, it's the one that's like, I don't know, right by the parking garage, that building where they've been doing construction. Yeah. And I ran over this big, huge piece of metal that was like this big around, like no joking, like it was that big and was sticking out of my tire like this far. Like it was a big piece of metal. And it was like, I opened my door, my tire pressure light came on. I was like, oh no, I must have run over something. My little indicator on my screen said like, I was already down to 20 PSI and whatever. And so I drive on and I park my car and I open my door and I can hear the air hissing out. And it was the back passenger side. Like, it was like the farthest tire from where I was and I could hear it leaking air. And I'm like, well, that's going to be flat in an hour. Like, no way. And it was. And so I had classes and many meetings the whole day until 8:30 at night. So I had to leave my car here and I notified security and let them know because they're here all night. And like, if you guys don't know, like the cops come and park in our parking lot a lot. Like, it's actually not that bad to be on campus at night because there's usually somebody here. But anyway, so I came back the next morning. Well, sometime over, like, I guess looking at the tire, or like when we had the windy day the day before, like that Wednesday before, it was that super, super windy day. I was bringing in my trash cans like on Tuesday or something, Tuesday, that's what it was. And I was wearing heels that day, and I tripped because the air caught me and I twisted my ankle. And so I had a sore ankle, and I thought that's all it was. Well, some combination of falling because of the trash can wind incident and the heels, and my tire, and having to bend down to mess with my tire, threw my back out so bad that on Friday morning I couldn't even get out of bed. Like, I physically like wasn't able to. Like, it was like I was like black. I literally was like starting to get stars in my eyes from the pain, just trying to get out of the bed. And so my back is killing me. And when I tell you that it is killing me, it's bad. Like, it's a kind of pain where I'm like, I'm lucky to have even showered in the past 3 days. So it's really bad. So bear with me if I end up needing to sit down during this, because you guys know how animated I get and need to walk around and whatever. Walking helps it, but it's like still not great. So have some grace for me today, please. All right, because I'm gonna try to go to the doctor today too. All right, so terminology of our antimicrobial. So this whole chapter is gonna be over antimicrobial drugs. So not just antibiotics, but antifungals, antivirals, and things like that. My chair over here for just in case. All right, so prophylaxis is a term that we use when we use a drug to prevent infection. So when you go in for surgery, sometimes they'll prescribe you antibiotics before you even get into the surgery. That's prophylactic. Whenever you are traveling out of the country, if you go anywhere in the subtropics, like in sub-Saharan Africa and places like that, they'll give you malaria drugs, and you have to be on malaria drugs while you're traveling to those regions. That's to prevent malaria. That's prophylaxis. So anytime we're preventing something, whether it's like having a baby, if you're trying to prevent a baby, so we talk about our birth control pills or condoms or things like that, you're just preventing the risk of this thing happening. That's what prophylaxis means. Okay, so antimicrobial chemotherapy. Chemotherapy does not mean cancer treatment. It means we're using a drug to treat something, anything. It doesn't have to be cancer. So if we're using a drug to treat cancer, then that's chemotherapy. If you're treating cancer with radiation, that's not a chemical. That's not chemotherapy. That's radiation therapy. So that's irradiation. So be sure that you're understanding that chemotherapy is what it sounds like. It's not a fancy or complicated word. It just means chemical therapy, just drug treatment. Anytime you're being treated with any drug, it's chemotherapy. My back hurts, I take naproxen before I come to work. That's chemotherapy for the pain. Okay, so that's all that means. So antimicrobial chemotherapy, drugs to treat microbes. Okay, antimicrobials is all inclusive for microbes in general, whereas antibiotics, we're just talking antibiotics only treat bacteria. It's really important that we remember that. Okay. All the other drugs, the antifungals, the antivirals, the antiprotozoals, the antihelminthics, those are all going to say their names in them. Antibiotics are effectively antibacterials. Okay. We have obviously drugs that are derived from nature, and then we can derive drugs from the nature drugs. So we know penicillin is a drug that was derived from fungi, and we got that drug out of that. But now we can make updates and chemical changes to penicillin and make ampicillin and amoxicillin and all those other cillins that we have. So those are semi-synthetic. We use a natural drug as our base and then make chemical changes to it. Synthetic drugs are produced entirely within the lab setting. We're not taking a natural drug and turning it into something. We're literally designing it based on our understanding of our microbes. Narrow spectrum, limited activity, broad spectrum, extended spectrum. Like this just means like a broad spectrum drug will get a whole bunch of bacteria, whereas limited spectrum, you might just only get certain kind of gram positives that have this molecule in them or something like that, right? So we kind of understand those concepts there. Antibiotics are often common metabolic products produced by fungi and other bacteria as well. So bacteria can produce antibiotics, which would mean if you're a bacteria and you're producing an antibacterial drug, an antibiotic, you would have to be resistant to that, right? So that's what we call an intrinsic resistance. We'll talk about that in a moment. These are the three things you need to know before starting your patient on antimicrobial therapy. The identity of the microorganism. So you need to know already what that microorganism is. We need to know the degree that it is susceptible to certain drugs. And we need to know the overall medical condition of the patient. So if this patient has kidney issues, we might not want to give them a drug that causes kidney issues on top of the ones that they already have. So this is kind of basic theory here, but let's move on to some details. If you wanted to figure out what antibiotics your patient, what your patient's infection would be sensitive to, then you would use our, beloved Kirby-Bauer technique, which we learned about in the lab. They literally use this in hospital settings. And so we'll have our plate of our patient sample and we'll stamp it with certain antibiotic discs and then measure that zone of inhibition, that area where we didn't get growth. And we can use that area where we didn't get growth in order to figure out how much antibiotic to give your patient. So you're not giving them too much, but you're not giving them too little either. But that zone of inhibition is that area where we don't have growth in it, right? And we know that the bacteria couldn't grow in that area. But just from our initial Kirby-Bauer plate with our zones of inhibition around it, do we know if it killed the bacteria or not? This is more or less review for the lab, right? No, we don't know that yet. So we can develop an antibiogram, which is a profile of which drugs your microbe is sensitive or not sensitive to. So would you pick VA, which is probably vancomycin, for treating your patient? Oh, sorry, on that particular image? I would hope not. Look how there's no zone of inhibition. If you gave your patient vancomycin, it would do literally nothing to their infection, but might clear out their normal microbiome, right? And so you're just opening up more stadium seats for their infection to take up. You could be making your patient worse by prescribing them the wrong antibiotic. And so that's why this concept is so incredibly important in when you're choosing your medication for your patient. Okay, and so remember, we measured that in millimeters. We also have this kind of strip here, the I keep bumping this, the E test, which starts off with a very strong concentration of antibiotic, and then further down the actual strip, you have the lower concentration. So you see down here where we have almost no space around it near the 0.50, that's like where you would say it like starts the clearing area. That would be the lowest concentration needed in order to control that antibiotic. And so you can use this as a direct way to test that, or you can use these outside edges around your regular Kirby-Bauer discs to measure your ZOI, and then that can help you calculate that. And so that concentration, that's the minimum amount needed in order to control the growth, which we can calculate from that E-test on the strip itself, or we can use our zone of inhibition and measuring that. That's called the minimum inhibitory concentration. That's the minimum concentration of that drug needed to control the infection. All right, so this is going to be useful in determining the smallest effective dose. Yes, question.
So I know like when it's big zone of inhibition, little zone of inhibition, that minimum inhibitory concentration, like it's just inhibitory, so they're gonna have to be on that drug longer than if you do something that was a little stronger.
So minimum inhibitory concentration. So the idea is that if you're inhibiting the growth of these microbes, the cells don't live indefinitely. So if you're on that antibiotic long enough, even if it's just inhibiting growth, the cells aren't immortal. So at some point, if you're on it for a week, the cells that were being inhibited from growing, because we talk about bactericide, because I'm assuming that's what you're getting at, right? The bacteriostatic side of it. So for the static sides of these drugs, if you're on that antibiotic long enough, even if it's just static, the cells are going to have to die at some point. They can't live forever, but the antibiotic isn't what's killing them. It's the fact that they aren't able to, make new copies of themselves and continue the growing process. The cells aren't immortal. They're only going to live for a week or two. And then at some point, they can't divide. They just die naturally of natural causes because
so that's why we use the minimum.
So you want to use the minimum concentration because let's say that you give them a higher dose. So we can use the minimum and it's still not work on your patient, right? We can use the maximum and it might work better potentially, but if it doesn't work still at the higher concentrations, now you've got a microbe that's probably adapted to surviving the higher concentrations that person could spread on to other people, and you're propagating antibiotic resistance that way. So we only want to use the absolute minimum concentration. So a lot of us are thinking of like, oh, antibiotics, they treat bacteria, as if we are so naive to think that they don't affect our cells somehow. That's very naive thinking. Your body has to metabolize these drugs, and a lot of these are going to be affected by, inhibiting your own microbes and your own microbiome, Inhibiting your own cells, if we're talking about DNA replication or protein, destabilization or inhibiting protein production, all of these ways that these antibiotics can function can affect your own cells. And then not to mention when your liver is metabolizing them, a lot of them can make toxic byproducts. So it could be harmful to your liver or your kidneys. So we don't want to use anything except the absolute minimum dose required because we want to avoid toxicity of that drug in our patients. And we don't want to promote antibiotic resistance at higher doses. May that make sense to everybody? Okay, so we're going to get into that a little bit here in a moment. But so the minimum inhibitory concentration is the lowest amount of that drug that you can use that it should be effective according to your Kirby-Bauer test. Okay, and so you can calculate your minimum inhibitory concentration, the minimum amount you need for whatever number of drugs that you're testing on your Kirby-Bauer. In clinical laboratories, they'll still do Kirby-Bauers, but it's not a person that's like measuring this stuff. A machine will do all of this interpretation for them. All right, so if your treatment fails after you do this minimum inhibitory concentration calculation and you treat your patient, these are the reasons why it would fail. The drug couldn't get to that body compartment. How many of you guys have treated a patient that has diabetes or has a loved one or a friend that has diabetes? Anybody? Okay. Anybody? So you guys are aware of the fact that diabetes limits blood flow to the extremities. It's incredibly common. There's other conditions that can cause that as well, but it's incredibly common, especially here in Oklahoma, where we have such a high obesity rate, and that's often linked to metabolic disorders like type 2 diabetes. You get poor blood flow to those extremities, all you have to do is stub your toe. Now bacteria are getting into that wound where people who have normal blood flow and a healthy immune system shouldn't have any issue with that. You probably would even need to wash it off in order to prevent the infection. But people with type 2 diabetes, their blood can't get to that area very well. So their immune system can't get to that area very well. And so any drugs that you use to treat the infection also can't get to that area very well. So that's why we see such a high percentage of limb loss in people with diabetes because of that poor blood flow. And when I'm telling you it's a high limb loss, I worked at Southwest Integris at their lab, and we would get multiple limbs a day from surgeries, multiple a day, just at one hospital here in Oklahoma. People getting amputations because of diabetes. Not for, huh? Yeah, that's losing your toes, that kind of a small level of amputation. But I mean, we see quite a few people that lose their entire limbs. I've had multiple students with family members who have lost entire legs just because of diabetes. I say just because, but associated with the pathology that comes along with it, right? The poor blood flow, the poor immune response. And then, of course, a lot of times, treatment at the hospital not being ideal either. We'll just put it that way. Miseducation of how to treat these things appropriately. So anyways, so inability of the drug to diffuse into that compartment. If your drug can't cross the blood-brain barrier and that person has meningitis, then that drug isn't useful for treating meningitis. So we have to think about that, as well as the blood flow to these extremities, which is an extremely huge problem in folks with diabetes. Resistant microbes. There could have been microbes that were resistant to that antibiotic that were involved in that infection that you just didn't pick up with your swab in that area, that were overgrown maybe by other bacteria on the plate. And this happens, so you might need to repeat the test in order to catch those resistant microbes. Or there could be an infection caused by more than one pathogen, a mixed infection, and that maybe that organism that is now living after treating, maybe that organism wasn't well treated or grown on your Kirby-Bauer test, and so you didn't see it for that. So those are the three reasons why your antibiotics wouldn't work if you did the Kirby-Bauer test appropriately. All right, so our therapeutic index, this is an important ratio that we do need to understand. I absolutely will have this definition on the test. Therapeutic index is the ratio of the dose of the drug that is toxic to humans to its effective dose. So what does this really mean? This means, we remember how we calculated that minimum inhibitory concentration. So that's the minimum effective dose. Now, if I told you that 0.5 is the dose that you need to treat this patient, and 0.5 is also the dose where we start seeing toxic effects in humans, now you're going to be less likely to want to use that drug compared to other drugs that might not have anywhere near the risk. So that's what the therapeutic index is looking at. The dose where it's effective versus the dose where it is toxic. And what you want is a huge discrepancy between those two. You want that dose where it's effective to be high and the dose where it's toxic to be low. And those are going to be your ideal choice drugs there. So I guess the opposite. I guess I'm saying the opposite of what I'm trying to mean. So so let's say, I'm going to draw it on the board because I'm otherwise it's painful. But if your toxic dose is 0.2 milligrams or something, okay? And then your effective dose, this is to kill or treat the bacteria effectively based on your, and I'll even write it up here, based on your minimum inhibitory concentration. So if your effective dose is, let's say 0.75. You have a range between 0.2 and 0.75. You have to get up to at least 0.75 in order to treat this. That gives you that buffer zone up to 0.75. If this is a 0.2, then 0.2, anything above 0.2, right, anything above 0.2 is going to be toxic. That makes sense, right? So anything above 0.2 is going to be toxic. So would you want to treat this patient with something that you know is going to be toxic?
No, ma'am.
Probably not. So you probably wouldn't want to reach for that. But if this was inverted, if this was instead the toxic dose was 0.8 and the effective dose is 0.15. Now you can go up to 0.8 if you needed to treat this person before it got toxic. Is that making clear sense? I had to draw it out on the board in order to think through it, but if you need to draw it out on your scratch paper, then draw it on your scratch paper. But this therapeutic index refers to that ratio between where it's toxic and where it's effective. And so what you want is for your effective dose to be lower than your toxic dose by hopefully a huge margin. So if you need to give a higher dose of something for it to be more effective, you're still not reaching the toxicity levels, right? Because we don't want to give too much beyond our effective dose, but we don't want to get too close to the toxic either. You also have to consider the fact of antibiotic resistance coming into play later on. Okay, all right. The therapeutic window is this range between these two. So when we think about drugs that don't necessarily treat infections, but can treat other diseases, does anybody know about lithium? Anybody heard of lithium? Okay, so lithium is commonly used medication to treat bipolar. So I don't say commonly, doctors steer away from it for a reason, okay? So lithium is one of those trace elements that we have to have in our diets in order for like our, proteins and things to work. And there is a speculation that people who have mood disorders that there is an imbalance of the amount of lithium that they need in their bodies. Maybe it's because their body isn't utilizing it as effectively, but maybe they need to be supplemented with more lithium. That's a speculation. Yes.
When I was 12 years old, I was put into a psychiatric hospital due to mental health reasons. And they put me on lithium because they misdiagnosed me with bipolar disease. And I cannot eat certain things now or else I'll violently throw up.
Yeah, so lithium is one of these drugs that in our trace element levels, we should have trace amounts of that in our diet. But the levels that they put you on at prescription levels of bipolar disorder medication or lithium, which again is not it is like their last line of defense typically for bipolar disorder. They're going to reach for things like lamotrigine and Depakote and things like that before they reach for lithium now. Because lithium's effective range for treating bipolar disorder and its toxic range are incredibly close. And I mean incredibly. If you're on lithium, they're going to do blood tests like at your first initial raising up to your effective dose, close to every 3 months. And then after that, for the rest of your life, every 6 months at a bare minimum. How do I know this? Because I was on lithium for 10 years. So I know because I took lithium as a bipolar patient.
And it ruins your body.
I don't take it anymore. But when I went on lithium, you guys, I had tremors so bad I couldn't go on stairs. Like I couldn't walk. Like my legs were so shaky I couldn't walk. I couldn't use like pens and pencils like very well. My hands would shake so bad I'd have to like have support on them. My thyroid doesn't work anymore because I was on lithium. My thyroid would have been fine if I didn't take lithium, but lithium drained my thyroid. Lithium is so toxic that many people who are on lithium for 20 years or longer often need kidney transplants. But this is their choice as far as what medication can work for them. If you've gone through all the other medications and they didn't work at all for your bipolar disorder and you are suicidal, and this is a real thing that people work with. And if you guys think you're not going to deal with this stuff in healthcare, think again, because you're all going to have to do psych rotations. You will be working with people like me who at face value on the street might seem perfectly normal, but they might have mood disorders where they have to take these medications. So if you are one of those people who is biased against crazy people, get that out of your head right now. There's something wrong with you if you think they're different from everybody else.
I don't know, there's something wrong with you if you think you're not crazy.
Yeah, right. That's kind of how I feel like everybody's on the spectrum. Everybody's on the spectrum somewhere. Right, and it's very commonly, they're commonly misdiagnosed with one another. Yes, AJ.
I just looked it up, and the dosage is 0.6 to 1.2, and toxic is 1.5.
Yes, that's what I'm saying. And so it's like incredibly close, like just a slight miscalculation. And so things like when you take lithium, if you are dehydrated, just by being dehydrated, not drinking enough water in your day-to-day ideas, your normal day-to-day practices, just not drinking enough water can shift you into toxicity. And then you will end up like, it's so bad, you'll end up in the ER from it. And so there were days when it would be hot outside where I wasn't drinking enough water because I was just trying to be a normal human being and live a life, where I would come down with symptoms of toxicity and have to be rushed to the ER and have to get fluids and treatment and things like that for the lithium. I don't take that shit anymore. But don't just come off of your medications either. You need to be coached by your psychiatrist if you do that. Or if you know anybody that's on lithium and they want to get off of it. Coached by your psychiatrist step by step all the way through. Because there was a reason you were put on that medication. And it's probably because you were trying to kill yourself or cause harm to others. And that's serious shit that you need to take seriously, right? So keep that in mind. But the same idea happens with any drug, whether you're treating a mental illness or whether you're treating an infection, whatever it is, all of these drugs have that therapeutic index that they have to think about. Okay, we clear on that? All right. So if you guys have any other questions about any of my medication journeys or my mental health journeys, I'm happy to share if anybody's interested. I'm completely open about it because I feel like reducing stigma is all about communication. So I'm pretty open about it and I don't have any secrets. All right, so things that can affect your drug's effectiveness. Your patient history has to be considered. So pre-existing medical conditions that oftentimes your patients aren't going to notify you about. History of drug allergies to certain classes of drugs. Obviously, your patient's allergic to penicillin. They're allergic to all the cillins. They're allergic to sulfas. They're allergic to all of those folic acid inhibitors that we'll talk about in a moment. And your patients often don't know this stuff as well. Underlying liver or kidney disease, which is why your common blood tests of your panels, your blood panels before you treat this patient should be done and analyzed before you start administering some of these more toxic drugs, especially like vancomycin and stuff like that. It's real hard on your kidneys, so you don't want to be putting this medication in somebody that has kidney disease if you can help it. Then being an infant or elderly or pregnant, because some of these medications can cause birth defects, you don't want to be giving this to somebody that could potentially be pregnant. All right, so we talked about the therapeutic index being the difference between the toxic level and the effective level and taking that into consideration. Selective toxicity is the concept that that you are being selectively toxic against the pathogen, but you don't want to be toxic to the person that's taking the medication. So it ties these things together. You want a drug that's going to be harmful to your pathogen, but not harmful to the host. That concept is selective toxicity. When you start talking about the exact numbers and ratios, that's therapeutic index. Those are different terms. People often confuse them on the test. So be sure you know the difference between those. Selective toxicity, that your best drugs are the ones that are going to block or kill our microbe pathogens, especially. And then they also won't be toxic to the person or hopefully their microbiome either, if we can have a choice. Okay. So penicillin, as we say here, drugs that have excellent selective toxicity. Penicillins block synthesis of the cell wall that are in bacteria. So it shouldn't be toxic to your own cells. That's why that'll be an example of an excellent choice as far as selective toxicity goes. So now we're going to talk about how our drugs will be targeting our bacteria and our microbes. Okay, so these are our targets. You remember how we talked about our targets in the control of our microbes. So we talked about how it can affect your cell wall or your cell membrane or making your DNA or your RNA or your protein or, yeah, so those 4, right? Those are the 4 targets for our control methods. It's the same for our drugs, except there's one more for bacteria, which is our folic acid synthesis pathway. We don't, as human beings, synthesize folic acid. We have to have it supplied in our diet. So it's called a growth factor. But bacteria do synthesize folic acid, and that's how they get their folic acid for building their proteins and their DNA and things like that. So it's a building block. So they synthesize their own. So we can shut down that pathway in those organisms. So those are our 5 targets. All right, and then here is a big old map of bacteria and where the drugs are going to affect the bacteria. Some of these drugs you won't be on your test. If it's not in your study sheet, you don't need to know it. On your study sheet, you need to know it. Okay, but here's a good little breakdown of what we're about to get into. All right, so the ones that are most likely to cause allergic response are going to be your penicillins and your sulfa drugs. So those also happen to be the best targets for our drugs. Targeting the cell wall are penicillin. Targeting the folic acid synthesis pathway are sulfas. And so people are a lot more likely to be allergic to those drugs actually as well. Our biome, obviously, if we can prevent affecting our biome, it will save us a lot of trouble in the long run. If you're having a UTI and you take an antibiotic that clears out your biome in your reproductive area, especially women like in the genital area, if we're clearing out all the bacteria in that area, then the yeast is going to overgrow. Remember, yeast aren't bacteria, they're fungi. So if you're taking an antibiotic that clears out all the bacteria, now the fungi is going to overgrow. Now you have what we call a super infection, which is the yeast taking up all those now open stadium seeds. The same exact thing happens with C. diff. So C. diff used to be named Clostridium difficile. They've changed the name to Clostridioides difficile. It's still in that Clostridium group. But C. diff, because it has the endospores, it can hunker down in the presence of these antibiotics and then, outweigh everybody. And a lot of people carry C. diff in their colon naturally. Usually have very small numbers of C. diff in your colon. It's very common. Not everybody has it. But if you have it and you take an antibiotic for your hip replacement, let's say, now you've cleared out your entire biome in your gut and all these stadium seats are open. And those endospores, when you're off of that antibiotic, those endospores are going to overgrow and take over everything. And that's how C. diff leads to pseudomembranous colitis.
Correct me if I'm being ignorant. I saw this on a South Park episode, but do people actually do fecal transplants thinking it's going to help?
So it does help.
Okay.
Yeah. It works. It's
I
effective.
didn't know if it was.
So we'll talk about that at the end of the chapter. Fecal transplants are a thing and they do work.
Okay.
Okay.
South Park was right.
So yeah, sort of. Yes. So it depends on how it's done. It is.
Okay.
It's a very common treatment for C. diff. Yes. So the idea is you're on antibiotics, and we can keep you on strong antibiotics, give you a fecal transplant, and then repopulate your stadium seeds with the good microbes before C. diff can overgrow. Don't do it yourself.
Question, where
Yeah.
do they get this fecal matter from?
It's supposed to be somebody that is close in relation to you. So like your kid or your spouse, somebody that you live with closely will donate poop. Yep, they'll poop in a bag, or not a bag, but you know what I mean. They'll poop in the cup and then put it in the bag and then donate it, and then they'll break that down and treat it. And then while you're anesthetized through a colonoscopy, they'll put the poop in your colon, and then it will seed in there and grow. You don't have to drink it. You don't. Okay. All right. So moving on. We're going to get into our actual antibiotics now. Okay, so this is our chemical breakdown, and these are the ones that we're going to have to know how these antibiotics work, right? So on the test, you're going to have questions like, how do penicillins affect bacteria? So this is our first group, our beta-lactams. You see this square ring, quote unquote, that's called a lactam, a beta-lactam ring. And any antibiotic that has that structure in it, that square in the red, that beta-lactam ring, is a beta-lactam drug. And a lot of these guys are related to penicillin. Penicillin is like the OG. So penicillin was the first one, and then all these other cillins were based off of penicillin. And so we have ampicillin, amoxicillin, nafcillin, ticarcillin. I don't know what these ones are. Cloxacillin, carbenicillin. If it has psyllin or psyllium or something like that in it, then it is going to be related to penicillin. And they are all beta-lactam drugs. And these guys inhibit the cell wall synthesis so that like specifically peptidoglycan synthesis.
So if someone has an allergy to
They can't ever take any of the penicillins. Yeah, it will cause anaphylaxis. Yeah, and so we have some other ones that also have the beta-lactam ring that operate the same way, but they are not psyllins. So these are our cephalosporins and our carbapenems. Carbapenems are last line drugs. They are like too effective as far as like your microbiome goes and can cause devastating effects in your body. So carbapenem is our last line drug. If you have a patient that's being put on carbapenems, then that patient has gone through a whole slew of other drugs before they had to be prescribed a carbapenem. So it's our last line drug. So if you have bacteria, which there are bacteria out there that are resistant to carbapenems, and those bacteria, generally speaking, are usually resistant to pretty much everything. And there's plenty of bacteria out there that are. Okay, so we're going to get to that one. But other drugs that affect our cell wall, bacitracin, which you guys know Neosporin, the triple antibiotic ointment. Bacitracin is one of those antibiotics. Okay. It affects the cell wall. We have isoniazid, it affects the cell wall of mycobacterium, like tuberculosis, it's a tuberculosis drug, and then vancomycin. So vancomycin is one of the few that when we get into the affecting protein synthesis, most of the mycins fall into the protein synthesis blocking pathway, but not vancomycin. Vancomycin affects cell wall synthesis, so always remember that. All right. All right, moving on. Now we're into the protein synthesis blockers. There's like two major groups in our protein synthesis affecting guys, the aminoglycosides and the macrolides. And a lot of these are mycins in general, or cyclins. So mycins and cyclins, okay? They affect the ribosome's ability to read your mRNA.
What was the second one? Aminoglycosides?
Aminoglycosides and cyclins. It's like tetracycline, lysyl-cycline, those guys. All right, so you don't have to know the exact mechanisms by which all of them work to block the ribosome, but you should know that a lot of them affect how the ribosome is going to function. And if you're interested, here's some breakdown of some of those drugs and how they affect the ribosome's ability to lock on and read your mRNA to make your protein product. So they block producing proteins by blocking the ribosomes. All right, so we have the tetracyclines. They bind to the ribosome to block protein synthesis, and glycylcyclines. It took me forever to say that word. I don't know what it is about it, but glycylcycline, it's a word, man. It's a word. All right, so then we have our macrolides. Again, these are a lot of the mycins, like azithromycin and clarithromycin. These just refer to the structure of the drug. I don't need you to memorize the structure of the drug in this class or anything like that, but do know most of the mycins, not vancomycin, but most of the other ones, and most of the cyclins are going to affect protein synthesis by inhibiting the ribosome from doing its job. Is that clear? All right, that's pretty much what you need to know about them. Moving on to our folic acid synthesis blocking drugs. Our big ones for our sulfa drugs. So the sulfas are the ones that block folic acid synthesis. They often do this by non-competitive or competitive inhibition in one of the enzymes involved in the folic acid synthesis pathway. Okay, so they're literally blocking enzymes that function for the bacteria to make folic acid. And the way they are sulfas, and here's our major groups of them. Sulfasoxazole. I'm not making you guys write them out. You just need to know. I would remember it this way. Does sulfur smell bad? Yeah, sulfur smells bad, right? We can agree on that. Does methane smell bad? Yes, so we can agree on that. So we have two kind of groups. The stinky drugs, let's just say it that way, okay? The drugs with stinky names fall into that folic acid synthesis pathway, typically. All right, so this is sulfasoxazole, silver, sulfa, diazine. So we've got silver in there, and we've already learned about silver and how those metals can affect protein synthesis and block that. So we have silver in there, and we have a sulfa in there. Trimethoprim. Trimethoprim is a drug that we often give in combination with sulfamethoxazole. So trimeth, there's 3 methanes in there. You can think of it that way. That's stinky. It doesn't have sulfur in its name, but you should be able to recognize that that would fall into the same category, okay? So it often comes with sulfamethoxazole. When you see trimethoprim in combination with sulfamethoxazole, that's Bactrim, okay? So these guys inhibit folic acid synthesis. And so often it's by competitive, sometimes non-competitive inhibition of enzymes in the folic acid synthesis pathway. All right, moving on to our quinolones. Quinolones are drugs that inhibit DNA synthesis. So we did our cell wall synthesis, we did our protein synthesis inhibition, and we did our folic acid synthesis inhibitions. Now we're on to the DNA and RNA synthesis guys. So these guys that block DNA and RNA synthesis can be toxic to us as well, because we often use similar enzymes in making our own, replicating our own DNA or making our own mRNA. All right, so that's the problem with this. And a lot of these guys can actually inhibit the helicase or helicase, however you want to say it, the one thing that unwinds the DNA in order to make the copies of it. So a lot of these guys actually act on that aspect, right? So these are the quinolones. They are high potency and broad spectrum. They're absorbed from the intestine very easily, but we also have major side effects here because it's going to affect our own cells, not just the bacteria. Luckily, we're a multicellular organism, so we can stand to lose some cells, but you don't want somebody on these long term, right? So you want to avoid that. So these can cause side effects like seizures and brain disturbances where we can't regenerate our brain tissue, right? So relating to the ability to make new brain cells and the functioning of those brain cells and the ability to heal and everything like that. So our quinolones, our fluoroquinolones, that's the name of the group. The fluoroquinolones always end in the suffix floxacin. Should sound familiar. So ciprofloxacin, levofloxacin, we call it Cipro. Most of us have heard of levofloxacin kind of in passing maybe, but it's a drug that's also commonly used similarly to ciprofloxacin. And Cipro obviously is a very commonly used one. Most of us have heard of Cipro. So its full name is ciprofloxacin. If it ends in floxacin, it is a fluoroquinolone. Fluoro, F-L-U-O, but flow to me, flox, okay? That's how I remember that one. So those are DNA and RNA synthesis inhibiting drugs. All right, moving on to the ones that target the cell membranes. So we've done the cell wall. Those are acylins and beta-lactams, includes cephalosporins and carbapenems. We did our protein inhibitors. Those were most of our mycins and cyclins. We did our folic acid inhibitors. Those were our sulfas and trimethoprim. And then we did our DNA and RNA inhibitors. Those were our fluoroquinolones that end in floxacin. So now we're at the cell membrane inhibitors. And the only one that I'm really going to test you on are the polymyxins. Okay, so you guys know we're back to that triple antibiotic. We already said the thing that affects your cell wall and your triple antibiotic is your bacitracin. So polymyxin affects the bacterial membranes. And there's one other one, neomycin. The mycin falls in that protein inhibitor pathway, mycins. So you have in a triple antibiotic something that affects the cell membrane, the cell wall, and protein synthesis all there. That's why it's so effective. So we're affecting 3 aspects of bacteria all at once. All right, so it's polymyxin. So this guy basically has a fatty acid component that it mimics how detergents work. So it just interrupts that cell membrane structure and weakens it. So these guys often work better along with other drugs, in combination with other drugs. And daptomycin is one that's often used for breaking up biofilms. And it's really useful in treating leprosy. So we use it as a combination drug with like clindamycin or something like that, which makes it more effective. All right, so moving on to our fungals. That's it for our bacteria. Now we're moving on to our antifungals. With our antifungals, the main ones that I'm going to ask you about will be our amphotericin B. I'm not going to ask you if it's a macrolide. I won't ever ask that, but you should know that amphotericin B is an antifungal. And it's actually one of the more commonly used antifungals, okay? So amphotericin B is a big one, and then our azoles. Most of the drugs that end in azole are antifungals. There's one exception that I'm going to come to in a little bit, right? So ketoconazole, fluconazole, miconazole, and clotrimazole. Those guys are commonly used for treating fungal infections. we hear a lot about ketoconazole, fluconazole, and miconazole. Miconazole is like what you get over the counter from yeast infection treatment creams, like Monistat, has miconazole in it. So those azoles, often ketoconazole and miconazole are also used for treating like athlete's foot. These are all fungal infections that we're pretty commonly aware of. And then a lot of these treatments can be obtained over the counter, but you can get prescription strength of these. If you have a yeast infection and you get a drug for treating the yeast infections, often fluconazole. So those azoles plus amphotericin B are the ones that I will test you on for the fungal. And I'll often just ask you which one is antifungal. You need to pick it out of the list, okay? Next are our antiprotozoal drugs. There are two groups of the antiprotozoal drugs, well, two drugs, kind of classes, I guess it kind of depends. So the two groups are the antimalarial drugs and then our anti-amoeba drugs. So those are two bigger groups that we're going to talk about today. All right, so our antimalarial. Oftentimes our antimalarial drugs are based off of quinine. Quinine was something that was derived from the bark of trees that was used to treat and prevent malaria. In high doses, it can lead to blindness. So a lot of the drugs now have been adapted to reduce those side effects that were associated with quinine. Primaquine and chloroquine still have quine in them. So that's how I remember that those are drugs that fall into the malaria category. And yes, I reserve the right to ask you which of the following are malaria treatment drugs, and one of the choices would be chloroquine. It's not all just going to be quinine. So be aware of what drugs fall under the category of quinine-based drugs. Chloroquine and primaquine fall in that category. And so what's the importance of these guys? Man, quinine has been used for so long in treating and preventing malaria. When the British were trying to take over the whole world, not too long ago, actually. So a couple hundred years ago, through time and time after that, up until like the 50s, pretty much. You guys remember that period of time when the British were trying to take over India, like occupied India for a while? Okay, so in order to prevent malaria, which is rampant in India, it's common, they would take quinine, and it has a very, very bitter taste. And so they had this soda water that was called tonic water that had quinine in it. And tonic water, to this day, you can buy tonic water that still has quinine. It says trace amounts of quinine in it, but it's more or less just for the taste of the tonic, okay? So you guys heard of gin and tonic? Gin is an alcohol that was literally made cheap so that people, and that was readily made from ingredients in the area that was really easy to make and made people want to drink their quinine. So that's really the whole reason that gin came about. It was cheap alcohol that made people more likely to, keep up with their quinine treatment so they wouldn't get malaria. It's made out of juniper berries, if you didn't know that. So that's where gin comes from. Gin and tonics were used originally to treat quinine. Cool story. So I'll ask you about those quinine-based drugs on the test. Our other protozoal treatments often treat amoebas. So our common amoebicide is metronidazole. So this is the azole. Remember how I told you how the azoles are going to treat fungal infections? Not this guy. Metronidazole. It treats protozoan infections, often more commonly the amoeba ones, as well as, and this is important, as well as anaerobic bacterial infections. So metronidazole. So the way that I remember that this one's different from the other ones, metro, I think of this guy grew up and went to the big city. So we've moved up as far as the different types of things that we're treating. So we've graduated to protozoal infections as well as the anaerobes. This guy is very commonly used to treat C. diff. You usually combine metronidazole with, does anybody know what other drug is combined with in order to treat it? Okay, it's going to be ciprofloxacin. So we'll combine ciprofloxacin with metronidazole in order to treat C. diff. And so metronidazole is very commonly used for anaerobic and bacterial infections as well as protozoal infections. And then our anti-helminthic drugs. So these are drugs that we more commonly associate with treating dogs for like heartworms or your pets for worms and things like that, but you can still treat people for their helminthic infections with the same drugs. The two biggest ones that I would be aware of would be praziquantel and ivermectin. And pyrantel is pretty commonly used as well. But these are huge in the anti-helminthic drug category. So be aware of these drugs as far as if I ask you which of the following drugs is an anti-helminthic, you'll be able to pick these guys out of a lineup. That's what's going to happen on the test. All right, our antiviral agents. Because viruses infect your cells and hijack your own cell machinery, you got a problem there. You can't just inhibit their pathways because they're using your pathways in order to replicate. And so a lot of times antiviral treatments are usually pretty specific to the virus. So we're targeting some special aspect of that virus. And often it could be how it docks with the cells, or it could be special enzymes that virus produces. Like we know HIV has a few special enzymes that it makes. It makes reverse transcriptase, which turns its RNA into DNA. Our cells cannot turn. I want to be very clear about this because there's been arguments already. One of my own, I want to say one of my own colleagues, but one of the other faculty members that teaches a humanities course
Oh, I know.
asked me about this because a student had asked him this question. He didn't know the answer. COVID mRNA vaccines. So we're talking about Moderna and Pfizer. Okay, so that's literally injecting your cells with mRNA, and your ribosomes will read the mRNA and make the spike proteins, put them on the surface of your cells, and then you created immunity against that, and that's how it works. There's rumors going around Instagram, Facebook, social media, whatever, that our cells can incorporate that mRNA into your own DNA, and your DNA becomes modified because of those. You guys should know by now why I shouldn't have to explain this to you, how that is impossible. It's literally impossible, okay? Unless you have HIV. Because HIV is the only cells that we know of that have the ability to turn mRNA into DNA. There's a few hepatitis infections as well. We're not going to get into this, okay? Unless you have these extreme infections where you got other things on your mind besides COVID, probably, that you cannot turn mRNA into DNA. That's one step, one hurdle you have to overcome. You also have to be able to insert that DNA into your DNA. There's 2 enzymes that you need in order to have that happen, and your cells lack this completely. Your cells cannot turn mRNA into DNA, and your cells can't insert that new DNA into your DNA. It's impossible. So next time you hear people talking about how these vaccines are changing your DNA, you're going to tell them about how you know better. Okay? Because you should by now. So impossible, like actually impossible. So HIV has special enzymes that allows it to do that, and it needs to have all 3 of those enzymes in order for it to be able to do that. And it comes special with that virus. So we can target those enzymes with drugs to inhibit HIV from replicating, which is exactly what our HIV medications do. They're going to target those special enzymes and make it so that they can't work anymore. And that's how we can keep viral loads to 0 with that stuff. Okay, so we have some HIV drugs. I'm not going to name the HIV drugs by name, but something you should know about HIV drugs is that they target those enzymes, either reverse transcriptase, which is turning the mRNA to DNA, or the integrase, which integrates the new DNA into the genome, or protease. Protease is an enzyme that HIV uses to clip up its protein products into the individual proteins. So we can target any 3 of those with HIV. So I would be aware of what those HIV drugs target, not necessarily their names, okay? All right, Relenza and Tamiflu. So zanamivir and oseltamivir. I'm going to call them by their trade names if I have it on the test, Tamiflu, for example. So these guys are targeting a special aspect of the flu virus called the neuraminidase. So flu uses neuraminidase in order to enter your cells, as well as to clip its budding. When it buds off and covers itself in your membrane and it clips itself off, it uses neuraminidase for that. It also uses neuraminidase to break down your mucus in order to get to your lung tissue, things like that. So Tamiflu and Relenza block that. I have a video on this. I don't really have, we might come back to this in a moment. Herpes. So herpes is going to be treated by acyclovir. Acyclovir inhibits the DNA and RNA replication aspects of herpes viruses and other viruses too. So acyclovir is the one that we can come closest to being more than just like a single spectrum antiviral. This guy can be used for multiple viruses that rely on DNA replication. So herpes viruses are one of those. So this includes valcyclovir, which is what we see in Valtrex. related to acyclovir. Come back to this if we have time. All right, so moving on. So that's all of our drug categories and all of the microbes they affect. Drug resistance is an adaptive response where microorganisms are going to tolerate a drug. This can happen due to the genetic versatility of these microbes, either from just spontaneous mutations and they just happen to survive the drug because of random mutations. We might think like that's unlikely. Like what's the odds that they're going to have a mutation that helps them survive this drug? That can't be what's actually happening. So if I'm talking about there's a 1 in a million chance that these microbes develop a random mutation that helps survival, just as there's just 1 in a million, how many microbes do you think are in an infection? A lot. So we're talking about it's actually really likely. So if there's a video that I have, hopefully I have it on here. I'll just shut up and wait until I get to it. Anyway, so intrinsic versus acquired resistance. Like I said, if you're a bacteria that manufactures an antibiotic to fight off other bacteria in your area, you better be resistant to the antibiotic you make. So being resistant to the antibiotic that you make is intrinsic drug resistance. Acquired drug resistance is where we're exchanging our genes. Remember those different ways that we can exchange genetic information in bacteria, that horizontal gene transfer? That we had our transformation, which we replicated that in our lab simulation. We have transduction, which is through phage infection. And we have the sex pilus conjugation. So we can actually shuttle it between the bacteria that way too. So that would be acquired resistance if you've got your resistance that way. But there is a minimal chance that mutation will be advantageous, but there's so many freaking bacteria, and especially with viruses, it's actually more common to see them become resistant to our antivirals. Let's see if we can watch this one, because this one I think is worth seeing.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, or some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And you see the different mutants repeat this at 100. After about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
11 days. And that's not any special bacteria, that's just regular old E. coli. It didn't have the genes to be resistant to the antibiotic beforehand. It just adapted to that. In 11 days, it became where it was sensitive to that initial antibiotic. In 11 days now has become resistant to 1,000 times what it normally would be treated with in 11 days. So when your doctors tell you to finish your antibiotic, if you do not finish it, I'm not kidding. That is the #1 way to lead to antibiotic resistance is by not finishing your antibiotics. You need to be sure you've killed your bacteria and not given them the opportunity to grow. So you want to be sure they're all dead. Do you have a question or are you just playing with your hair? Okay, I just want to be sure. I didn't want to miss you. Okay, so let's keep going. So that's antibiotic resistance in action. These are the ways that antibiotics can lead to resistance. They can lead to developing new enzymes. So often you're going to get new genes from your, having bacterial sex with your sex pili, partner. They gave you a new gene. That new gene codes for an enzyme that can inactivate or break down the drug. So that's new enzymes that can break down the drug or affect the drug. They can have a change in their permeability or uptake of the drug. This is usually due to mutations. They have mutations in the channel that the drug uses to get in, so the drug can't get in anymore. Or we can eliminate the drug immediately. So as soon as that drug gets in, some bacteria have the ability to shuttle that drug out immediately before it can act on the cell. So that's 3 ways. We can also have binding sites for the drug would be decreased to the actual way that the drug acts on whatever its target is. So if it affects your ribosome, maybe the place where it binds to the ribosome has changed somehow. So we're not talking about getting into the cell. We're talking about whatever it affects inside of the cell. Its targets there can change. Or we can affect metabolic pathways, where like if your sulfa drug is a competitive inhibitor for your enzyme that lets B become C, and so we are usually inhibiting here, well, these guys will just make a new pathway to get to the end product. And so there's all sorts of ways that our mutations can work that way. So those are the 5 big ways. We have affecting the enzyme itself, by affecting the drug itself with a new enzyme. We have the permeability, how the drug gets in. We can shuttle the drug out immediately. We can affect whatever the target is of that drug, change it somehow, or we can make new metabolic pathways. 75% of antimicrobial prescriptions are for throat, sinus, lung, and upper respiratory infections here in the world. Most of our drugs are targeting those things. And most of the time, those things are actually caused by viruses and not by bacteria. And so you're just creating a new environment for bacteria to have that pressure on them for evolution. So we're adding to that. We also have the shotgun approach to antimicrobial therapy. Oh, you have an infection? Here's some drugs. It'll probably take care of it. That's the shotgun approach. And then excessive microbial drugs in the United States are exported to other countries where they might not be used appropriately there. And then that will lead to resistance in those countries and then can be transferred back to us. 80% of all antibiotics in the United States are given to livestock. So 80% of all antibiotics in the United States are given to livestock. And I want to make this clear. Those livestock are not sick. So why are they giving them antibiotics? To make them hardier and healthier and more resistant to the infections, to prevent infections and things like that. But now we have the development of these new microbes in the cattle or in wherever, whatever livestock, and then can transmit those microbes to humans that have now developed resistance within the livestock industry, where the livestock never needed those antibiotics to begin with. This is a huge problem because those pathogens can jump back to humans or transmit those antibiotic resistance genes to human bacteria. There's a very, very real possibility, and I want to say very real possibility that we're going to enter a post-antibiotic era where no longer will any of our antibiotics work. If you think that antibiotics are still perfectly effective and there's no risk for really this being an issue for us in the near future, then you are delusional. Because there's already plenty of bacteria out there that are completely resistant to every drug that we have available. They just aren't treatable. So we can actually define our risks for our infections as urgent, serious, or concerning. I want to show you, this is the biggest. These are our urgent threats. You want to notice what's not on here? MRSA, because it's not one of the most serious threats. Y'all think MRSA is serious? I'm telling you, that's baby talk. Babies. We've got way bigger threats out there than MRSA. One of the examples here, like the best example, C. diff, extremely difficult to treat C. diff. Even with those drugs that I'm talking about, because the more we treat C. diff and the more ineffective that can be because it can hide out in these little sacs inside of your colon, especially if you have diverticulitis, you get these little microscopic sacs in your colon that can just trap bacteria and the drug isn't getting to them and they can survive it. And more, they can be exposed to it enough to allow them to adapt and become resistant. And you're like, what's the odds of that? Actually really high. It turns out it's really high. Look at this, drug-resistant Neisseria gonorrhea. When we say drug-resistant, I mean 100%. So you get this strain of gonorrhea, which has become rampant in Japan and has been spreading around the world. You get this strain of gonorrhea, when you go to the doctor and they're like, oh, well, you have gonorrhea, you have the drug-resistant gonorrhea. What do they do to treat you?
Yeah.
They can't. You get sent home and you have gonorrhea for the rest of your life. And you're positive for gonorrhea forever. That's what it is to not be able to treat these infections. You either die from them or you just have them forever. That's what happens when you can't treat a infection with an antibiotic anymore. So you're gonna have these infections forever, or you die from them. Yeah, like you go home and we're like, so you have gonorrhea forever. Maybe use condoms. Do you think that person got gonorrhea by using protection?
No.
Right. So it just gets spread and spread and spread. Some of these diseases as well can have a limited to no symptoms and signs associated with them. We'll talk about that in chapter 24. It's the last chapter where we're doing sexual transmitted diseases. But you know, a lot of these can have no signs or symptoms for some of the people. And so they're spreading these completely resistant bacterial infections to people. And they're probably aware of it. They just don't have any signs or symptoms. They just don't want to tell you because they're embarrassed a lot of the times. So keep that in mind. So Candida auris, a fungal infection that's become very resistant to antifungals. It's really common in people who have autoimmune diseases that are taking things like Humira and things like that for their treatment. Their normal body immune system can't fight off this fungus anymore. And so our treatment of trying to get rid of that repetitively, that's mutated to a point where it's no longer treatable. And anything that's carbapenem resistant is at risk for being resistant to pretty much everything we can throw at it. Then on our second risk, our serious threats, that's where we see MRSA and other things like vancomycin resistant enterococci. These are also very commonly associated with hospital infections. So how do we help our bodies along with this stuff? We have our probiotics. So we fill up our stadium seats with good bacteria to prevent the bad guys from being able to grow. So that's what probiotics are all about, giving yourself these healthy microbiome so that you can fill your stadium seats with healthy guys so the pathogens can't sit down. And then we have prebiotics to feed those guys. And then our last slide, of course, is going to be about treating Clostridium infections. If we can get the Clostridium count down in someone's body by treating with antibiotics, we can then repopulate them with a new microbiome, and that's often by fecal transplant. And so usually we're going to get fecal donation from somebody that's very close to them in their life because they're more likely to be able to propagate that in a healthy manner. And then, give them a new healthy microbiome to facilitate their recovery from C. diff instead of constantly having C. diff overpopulate their stadium seats, fill their stadium seats up with other healthy guys to keep the C. diff numbers down. Often done through colonoscopy. So we'll go through the questions really quick before we head up to lab for the review. Actually, we don't need to go to the lab to do the review. We just do it in here. Sound good?
Yeah, chairs are coming.
That's true.
Here or in the lab?
Here.
Okay, I was gonna say, I was like, what are you talking about? Yes, in here, I agree. Okay, so we'll just do it in here. We'll stay in here. I'll go put a note upstairs just in case anybody shows up. I don't think everybody's here, but all right, selective toxicity. When we talked about the selective toxicity, that was the idea that you want to be toxic to the pathogen and non-toxic to the person that has the disease, right? And remember the difference between selective toxicity and the therapeutic index. Selective toxicity is that idea that you want to be toxic to the bad guy and non-toxic to the patient. Therapeutic index is the actual ratio between the drug's toxicity and its effective dose. All right, which part of bacterial cell does ampicillin affect? The cell wall. All the cillins affect the cell wall. Which aspect of the bacterial cell does tetracycline affect? The cyclin, remember the cyclins and the mycins, most of those guys affect protein synthesis. What classification of antibiotics does ciprofloxacin fall under? So those are DNA and RNA synthesis inhibitors. So helped with inhibiting that helicase function. So these are our fluoroquinolones. And then what type of infection is miconazole used to treat? So miconazole is used to treat fungal infections, right? All right, that is it for this. We'll have a little bit of a break, and then we're going to jump into the lab thing. I just wanted to put a note on the other door. Ooh.